My name is Professor Alexander McFarlane. I'm from the University of Adelaide in South Australia, and I'm the chair for this afternoon. And it gives me great pleasure in chairing this session and to run this symposium, which has got so many illustrious speakers from the four corners of the globe. And the session today is about new perspectives on trauma and disaster intervention. And the first presentation is going to be by Dr. Barbara Forresi. And what we're going to do is we're going to have each of the presentations, and then we'll have plenty of time for questions at the end. Now, Barbara is a clinical psychologist, PhD, and she has a research grant, and she collaborates with Professor Caffo and his group at the University of Modena and Reggio Emilia. She received her PhD from the University of Modena and Reggio Emilia. Her clinical and research interests are focused on traumatic events and their impact on children and adolescents' development, and she's going to be talking about evidence-based interventions and challenges of trauma research with children at the school intervention program after the 2002 earthquake. Thank you very much.
Well, good morning to all of you. Let me start by saying that it's a real privilege and an honor to be here for me and to take part in this symposium with such a keynote speakers. And it's also a pleasure to present an Italian study concerning post-traumatic effects and reactions in a sample of children and adolescents exposed to natural disasters. In October 31, 2002, the area of Campobasso in the south of Italy suffered an earthquake measuring 5.4 on a Richter scale. Although the magnitude of the earthquake was relatively low, the most dramatic effect was the collapse of a school in the town of San Giuliano di Puglia, in which 26 children died under the school collapsed, together with one of their teachers. The earthquake also damaged many buildings, leaving hundreds of families to be relocated to tents and temporary houses. While the school had been flattened, the damage to the rest of the town was comparatively slight. However, the effect upon the town was traumatic, not only because everyone knew or was related to at least one of the children of the school, because San Giuliano is a very small town of 1,500 people, but also because it took many hours to firemen and rescue workers to bring out children's bodies. And this happens in front of a crowd of parents and adolescents. The first, you can see here some pictures of the intervention group composed by Professor Laor, Dr. Leo Vollmer, Professor Caffo, and myself. The first aim of this study was to evaluate the effectiveness of a brief school intervention program, the class activation program, 5 months after the earthquake. We also had secondary goals were to determine post-traumatic symptoms, dissociative and grief symptoms, as well as school adaptive functioning in children and adolescents exposed to the earthquake. We also evaluated the relationship among type of exposure, pre-existing risk factors, parental psychopathology, city of residence, and the severity of symptomatology. Participants in this study were 470 children aged 3 to 14 years attending the school, the prefabricated school of San Giuliano di Puglia. This sample included children from 3 towns in the earthquake zone: San Giuliano, the epicenter where the school collapsed, and Bonifro and Colle Torto, that are only 3 kilometers far from San Giuliano. In Bonifro and Colle Torto, damage to buildings were less extensive, and there were no losses of human life. Assignment to experimental and control group was not determined randomly, as some teachers were not available to take part in the intervention program, but accepted to take part in the assessment process. The students of their classes were involved as comparison subjects. As a result, 273 children and adolescents participated in the class activation program and were compared with a control group of 197 children and adolescents. The intervention group did not differ significantly from the control group at the baseline, except for the degree of exposure and the PTSD level. Both were higher in the experimental group. As we didn't use a random assignment, this study was undertaken with a quasi-experimental design and conducted with a two groups ABA design. Group 1 was assessed at pre-treatment, provided treatment, and then reassessed at post-treatment, while Group 2 was assessed at baseline, then following treatment for Group 1. The intervention lasted 8 weeks, and 6 weeks later, the children were assessed for a second time. As far as the diagnostic tools we used, children, parents, and teachers were administered several questionnaires. Post-traumatic stress symptoms were evaluated by using the 20-item self-report Child Post-Traumatic Stress Disorder Reaction Index by Pinos. Ratings of grief and dissociative symptoms were obtained by using the Traumatic Dissociation and Grief Scale. Parents also completed a preschool children's response to stress inventory and a list of risk factors. Therefore, the individual degree of exposure in terms of personal injury, being caught under the rubble, seeing dead of severe injured individuals, as well as the presence of previous traumatic experiences such as losses, hospitalization, or divorce, parents were evaluated. In addition to this, teachers completed a children's school performance teacher's report, so they were asked to assess each child on 3 domains of adaptive daily functioning. Parents' PTSD and dissociative symptoms were assessed by using the Davidson Trauma Scale and the Traumatic Dissociation and Grief Scale. The Class Activation Program was developed by the Cohen-Harris Center for Trauma and Disaster Intervention of Tel Aviv, and it has been implemented after the earthquake that hit the Turkey in 1999 with good results, confirmed by a recent follow-up. This is a teacher-based intervention. The treatment is manual-guided and consists of 8 two-hour meetings implemented by teachers over the course of 8 weeks. As teachers were asked to be involved in this intervention, the process initiated with a group session with a modified debriefing protocol, conducted with the objective of processing and restructuring teachers' traumatic experiences, normalizing their responses, and enabling trauma-related effects to be expressed and worked through. Therefore, we help teachers redefine their role as educators, enhancing their role to match complementary needs in their students rather than merely covering regular curricula. The Class Activation Program began also with an introductory meeting with the parents to engage them in the process, to provide information related to the program, and also to educate them about children's suspected reaction to the earthquake. As you can see in the 8 two-hour meetings of the Class Activation Program, we focused on various aspects of the recovery process, from restructuring traumatic experiences, dealing with fears, and establishing a safe place, planning for the future, and so on. The program combines cognitive behavioral techniques, psychoeducational modules, play activities, and ongoing documentation in personal diaries. And the goals of the school activation programs were challenging avoidance as the core of the post-traumatic response, but as well as normalizing children's responses to stress, preventing and reducing expected high psychopathology and PTSD rates in children after the earthquake, and promoting psychological well-being of children. What about the results? As far as the severity of the exposure, we found that many children were directly affected by the earthquake. 30% suffered from personal injury, 8% was caught under the rubble, and 21% suffered personal losses. What about clinical symptoms in children and young people? 5 months after the earthquake, 22% of children reported severe or very severe levels of PTSD symptomatology. And similarly, in preschoolers, we observed anxiety, fears, and sadness symptoms that were frequently reported. As far as preschoolers are concerned, it is noteworthy that regressive symptoms were among the less frequently experienced symptoms. We found that 100% of parents reported that their little child didn't seem more babyish On the contrary, preschoolers were described as more independent, more adult-like, and more likely to help parents in daily activities. Grief and dissociative symptoms were also reported, and grief symptoms particularly were reported by the highest percentage of children in comparison to dissociative symptoms. We performed also some correlation analysis, and in order to investigate the contribution of sex, exposure, previous risk factors, and parental psychopathology to predicting the severity of children and adolescent symptomatology. And what we found is that females score higher than males on the Child PTSD Reaction Index and on the Trauma, Dissociation, and Grief Scale. We also found that older children tended to be more severely affected than the elementary school children. What about previous traumatic events and previous psychopathology? As far as previous traumatic events, it has been found to be a vulnerability factor. In fact, children who had been exposed to 5 or more previous stressful events were more likely to show higher level of symptomatology. Instead, the data suggests that the degree of exposure to the earthquake strongly contributed to the severity of symptoms. Those identified as having the higher levels of PTSD was those to have been caught under the rubble, to have seen severe injured people, to have suffered personal losses. Similarly, more severely exposed preschoolers showed higher levels of sadness and fears. There was also a similar positive correlations with the city of residence. Our data revealed a dose of exposure effect, with the San Giuliano's group scoring significantly higher than the other two groups on the Child PTSD Reaction Index. Finally, as reported in previous studies, children's symptoms correlated with disorders in both parents, and particularly we found that the severity of PTSD in symptoms were mainly affected by the presence of PTSD, dissociative, and grief symptoms in fathers. Our data is consistent with a study of Kilic and colleagues published in 2003. He also found that father psychopathology was particularly influencing children's psychopathology. As to the outcome of treatment, we couldn't perform the analysis in the preschool children sample because because of the small sample size. As you can see here, box plot shows that PTSD, dissociative, and grief symptoms significantly decreased in the groups involved in the school reactivation program. This is the PTSD levels and the dissociative, the different scales of the traumatic dissociation and grief scale. And therefore, they had a significant reduction in the symptomatology, as well as an improvement in academic competence and social behavior, as you can see here in the experimental group. However, was it an effect of treatment, or was it actually a natural tendency to improve over time? The treatment effect did not appear to owe to the mere passage of time, as the control group showed no changes in PTSD, even if there is a decrease in the rates, and dissociative and grief symptoms from baseline to post-treatment did not change, but they increased. Did not decrease, but they increased. On the contrary, we observed a significant decrease from pre-treatment to post-treatment in the school adaptive functioning. Between group analysis in the treatment period, also in the post-treatment period, also put in evidence that the control group scored significantly higher in dissociative and grief symptoms and significantly lower in the school functioning. We also exclude that the improvement could be an effect of a parental psychopathology improvement, as we didn't observe any change in parental psychopathology from baseline to post-treatment. The results suggest that children and adolescents benefit from early school activation program. The school intervention provided children with a significant symptomatic reduction, also enhancing their overall adaptive functioning. Let me say, however, that this study has many strengths, but also several limitations. The strength include that, to our knowledge, this is the second controlled study to evaluate the effectiveness of a school intervention after a natural disaster in Italy. We had a control group. The sample was composed by 470 children and adolescents. The first assessment was made 5 months after the earthquake. The school intervention was manual guided. We focused on adaptive daily functioning as well as on symptoms. And as far as symptoms are concerned, we did not focus only on PTSD, but also on grief and dissociative symptoms. We gathered data from multiple informants and enriched our study with some measure of parental assessment. However, at the same time, several limitations must be considered. First of all, this study was undertaken with a quasi-experimental design, as we didn't use a random assignment. As we didn't have instruments to measure PTSD, trauma exposure, or grief validated in an Italian population, we translated and linguistically validated the English version according to international guidelines. However, we had no time to validate them in an Italian population, making them suitable for the study. And moreover, a high non-response rates affected this study, resulting in a reduced sample size and in an increased sampling variance. Therefore, certain analyses, such as subgroup comparison, were hindered because of limited sample sizes. At this proposal, we should have paid more attention to at least 2 variables, maybe the selection of the training and the interviewers, as well as we should have administered a smaller number of instruments. Another interesting point is the co-presence of a number of psychosocial intervention at the same time. Therefore, we don't know whether the children involved in the school activation program received another intervention, psycho-educational intervention. In fact, after the earthquake, nobody was in charge to coordinate research and intervention in that area. And this coordination is fundamental not only to protect survivors and their well-being, but also to facilitate research activities, avoid duplication of efforts, and ensure that quality data are obtained. We are now working on follow-up data, so we are waiting for the results concerning the follow-up. Some of these limitations are common to disaster mental health. As Chenton wrote in an article published in 2002, the majority of studies concerning post-disaster treatment for children have significant methodological limitation. Participants are not randomly assigned, post-trauma symptoms are not specifically measured in the child study, information on attrition are not provided, and the treatment are not protocol-guided, making it difficult to know what was done. However, some of these limits are specific to Italy. Nowadays, there are excellent examples of research in this field, and guided by these experiences, Italian researchers must continue to thrive and grow, trying to overcome the existing obstacles to research in the field of trauma. And the key points include to allocate funding prior to traumatic events in order to develop standardized assessment tools for traumatic exposure and traumatic reactions. We need mental health professionals to be properly trained in research methodology and field research in post-disaster environment, which is a particularly research context. And finally, we need to identify a coordinating body for all research on a specific traumatic event. And as we are in Florence, I'm closing with Dante from the Divine Comedy. Thank you very much.